Hello, my name is Bogdan. I'm one of the nurses on intensive care. I will be teaching you the renal system. First, we will look at the major components of the renal system. As you can see, we have the kidney, we have some vessels here, and then we have the bladder, and eventually the urethra. Blood normally goes from the aorta into the renal artery, which innervates the kidneys. Blood then comes out after it's been filtered through the kidneys, through the renal vein, and into the vena cava. From then, all of the filtered blood and the filtered components, the urea, ammonia, everything, goes into your urethra and into the bladder, where the bladder fills up steadily until a signal is sent to your brain that you need to pee. From there, it goes through your urethra. This is the kidney. It is made up of 3, maybe 4 components, which should explain a lot of the functions to you. The first component is the renal cortex. This is highly vascularized, as you can see from the picture, and that is where the glomerulus, or the Bowman's capsule, lives. Then you have the renal medulla. The renal medulla is a very salty area. It's triangular in shape, mostly because you've got the nephrons sitting at the top next to the cortex, and they all have the loop of Henle going straight through into the medulla. They are connected to collecting ducts, which are then in turn collected to the renal calyxes. The calyxes empty out into the urethra. We will now take a closer look into the renal system and the functional unit of the renal system. The first is the juxtaglomerular. The second is the cortical nephron. As you can see, the glomerulus, or this capsule, is in the cortex for both. Then you have the proximal convoluted tubule, which leads into the descending loop of Henle. For the juxtaglomerular nephron, it leads all the way into the lower medulla. So it goes across the cortex and across the medulla into the lower medulla. Unlike the cortical nephron, which has a loop of Henle, make its ascending climb back up into the distal convoluted tubule just before the lower medulla. This is because there are 2 different concentrations of salts in the middle medulla and the lower medulla. The lower medulla is more salty. Because it is more salty, water can be reabsorbed more easily into the bloodstream. We will now be looking at 3 principles of the renal system. The first principle we'll be tackling is the glomerular filtration. As you can see, this is the Bowman's capsule, or the renal corpuscle. It is made up of 2 layers, the peritoneal layer, which is the outside layer, and the visceral layer, which is made up of podocytes. The podocytes innervate the blood vessels, and they act like a sieve, preventing the flow of larger molecules such as red blood cells and proteins. As you can see here, you have the blood vessels that innervate the Bowman's capsule. You have an afferent arteriole and an efferent arteriole. The afferent arteriole brings blood into the Bowman's capsule, and the efferent arteriole takes blood out of the Bowman's capsule. The afferent arteriole and the efferent arteriole combine to make the glomerulus. Normally, the afferent arteriole carries blood from the heart. The heart pumps at a very high rate, at high pressure, which causes a hydrostatic pressure, forcing the blood to move across the membrane. The sieve prevents the flow of larger molecules like proteins, plasma proteins, and red blood cells, and allowing the flow of other molecules like sodium, chloride, and water to flow into the bone space, effectively filtering the blood supply. If you have a good blood pressure or a normal blood pressure, this process works very well because you have a strong hydrostatic force. However, the hydrostatic pressure must go against pressures that flow against it. For example, the hydrostatic pressure flowing back into the blood vessels, and the oncotic pressure, because as molecules are being filtered out, or smaller molecules are being filtered out of the blood vessels, the blood vessels end up having a much higher concentration of larger molecules and a much lower concentration of water, causing some water to move back. Therefore, if the hydrostatic pressure is not high enough to overcome the forces pushing against it, glomerular filtration will not take place. The second principle we'll be covering is tubular reabsorption. Tubular reabsorption occurs in the proximal convoluted tubule, the distal convoluted tubule, and along the whole loop of heme. However, we'll be focusing on the proximal convoluted tubule and the distal convoluted tubule at the moment. Essentially, sodium moves across from the tubules back into the blood using protein channels via facilitated diffusion. This increases the positive ion concentration within the blood, creating an electrochemical gradient which drags the chloride ions and the bicarbonate ions as they are negative. This influx of ions within the bloodstream decreases its concentration. Thereby, water can now move via osmosis from a high concentration of the tubules towards the lower concentration of the bloodstream. Water, however, has solutes within it, thereby dragging solutes along. Some of these solutes include glucose, amino acids. The same principles of tubular reabsorption apply at the loop of Henle. However, the structure of the loop of Henle limits where reabsorption occurs. For example, the ascending limb of the loop of Henle is thick. Because of that, water cannot be reabsorbed into the blood. However, this allows the free movement of electrolytes in the same process used in tubular reabsorption. You have the sodium going across the gradient first, creating a positive electrochemical charge in the blood, allowing chloride ions to be reabsorbed back into the blood via the electrical chemical gradient with no osmosis. This is why the other part of the loop of Henle, the descending limb, is very important because it is thinner than the ascending limb and therefore is permeable to water but impermeable to salt. The reason it is impermeable to salt is because of the concentration of the blood as it goes past the descending limb. It already has the sodium ions and the chloride ions. However, this seems a bit backwards because you would assume that the blood would go co-current with the flow of the solutes to help diffusion along the process. However, as you can see, with co-current flow, diffusion may occur at a faster rate initially, but eventually an equilibrium would be reached where no more diffusion could occur. Therefore, a countercurrent flow where the blood flows from the ascending limb past the descending limb allows for near 100% of diffusion to occur at a slower rate. However, diffusion occurs throughout the entire time, maximizing the surface area. This brings us back to the two nephrons. We looked at in the beginning, the juxtaglomerular nephron and the cortical nephron. The juxtaglomerular nephron loops down all the way into the saltiest part of the medulla. Because of the salt concentration, water is more readily absorbed back into the blood. However, this is another area where tubular secretion, the third and final principle we will be discussing, occurs. In tubular secretion, solutes and waste products go back into the tubules. The most notable areas that this occurs is the proximal convoluted tubule, the distal convoluted tubule, the lower part of the loop of Henle, and the collecting duct. As we were just speaking about the loop of Henle, because of the salt concentration within the lower medulla, urea secretion back into the tubules is much higher, and less energy is used, making for an efficient system. The main parts of tubular secretion that you need to be aware of is that it eliminates excess potassium and excess salts or solutes. It also removes substances not already in the filtrate, further eliminating waste. For example, urea and the lower part of the loop of Henle, drugs and creatinine, which is secreted back in the tubules in the proximal convoluted tubules. In the distal convoluted tubules, it is more likely that potassium and hydrogen ions are secreted back into the tubules to help maintain blood pH by adjusting the concentration of acid within the blood. To conclude, I look forward to teaching you all in our renal class. To prepare yourself for the renal class, I would probably read at least one of the two options provided. KDIGO guidelines are very, very important, and they'll be very useful for your exams. NICE guidance will give you a pretty basic overview of how to define AKI for when we do it in class. I would also recommend reviewing the latest Cochrane review on colloids versus crystalloids. It is likely that we'll be doing a discussion about which fluid to use for a patient who has acute renal failure. All in all, hopefully the video was short and sweet. Thank you. I'll see you in class.